there are some things that are repeats, although like in the case of dissections, I really want to make sure you guys understood that. Aneurysms, but anyway, kind of a short, it's probably going to be a short lecture today. I thought about getting into the next chapter. So this is chapter 8, by the way, page 97 of the vascular book. I thought about getting into 9 as well, which really goes into endarterectomy, the surgery itself, but then what we're left with and what we were exposed with. Let's see if we go into 10. Oh, and the next one after that would be getting into the circulation inside the head, actually, which we have a very difficult time seeing because of our bony skulls. But the circle of Willis is something we will have to learn. Okay. Anyways, without further ado, I just want to go through this. Like I said, it's probably going to be a short lecture today. I'm going kind of in the order of the book. Tortuosities, torturous, meaning it's been tortured. So this is not terribly unusual, not so much in the CCA, but I've certainly seen these in the, let's say we'll just say maybe the ICA. And the vessels do a complete loop-to-loop. And we seem to find these in older people, generally older ladies. Well, I would say old men, old ladies. And it really is a matter of how much they've shrunk in their life, in their old age, how much shorter they are than they used to be, how they hold themselves. Because what actually happens is that the vessel grows to a certain length and perhaps had a little bit of tortuosity in their younger adult life, but then as their neck literally gets shorter, the vessel doesn't get shorter with it. The vessel kind of kinks. That's one possibility. The other possibility is they're just born this way. So it does present a problem. It could be really awesome. If you get a beautiful picture of it, it's just awesome to look at, but oftentimes not so easy to scan. And what I've drawn here is I've partially filled it in because, of course, we're having a bit of a change in direction, aren't we? So we could expect that as the, let's see, goes away right about here, there's going to be some different colors. Let's see, that's going away towards more or less like this. And of course, that's just simply, that color difference is simply just a matter of direction. So not really unexpected. What can also occur and be a little less expected is the velocities around the vessel. If you imagine a centripetal force is going to force blood to travel faster around the outside than it does on the inside. So faster, that means we can probably run into some aliasing. Oops. Some aliasing around the outside of a turn. And so we do, of course, want to be aware of that. Show a little bit of color right there. So some people will tell you, and like when I used to do this, I would scan, I would put my gate, in all sorts of places around here. whoops, and hit the entire vessel. But I would have to explain some things. I would end out having to explain to the doctor why the velocity was, let's say, 100 centimeters per second there, and let's say 130 here, or 140 or 150. And I felt compelled. I had to explain that. I said, well, doctor, it's around the corner. And I don't know if it was more me trying to prove to the doctor that I understood centripetal force or what centripetal force would do, or if it was really helpful. In retrospect, if I'm looking at this vessel and the aliasing, and you have to perhaps say aliasing due to tight curvature of vessel, leave it at that. If you do spectral, it would be best, probably, do spectral, well, certainly before and after. No question about that. And then inside the vessel, just choose wisely. If you do, if you chose this spot here, you would angle correct there, angle correct like that. And if you were to choose, by the way, this spot, which is probably not the best, your angle correction would be more or less like that. That angle correction, and that's pretty close to zero. You can achieve a zero with this very easily by looking straight down on a curve like that, and your angle correct would essentially be in line with everything else. Let's do my angle correct in a different color. My angle correct is set really to zero at that point. And that's certainly possible. And there's nothing wrong with that. Remember, 60 degrees is a strong suggestion, but anything under 60 degrees is still very acceptable. So you can do that. So in other words, the tricky part is making sure you're not getting all sorts of stupid vessel velocities that are not necessary, simply due to tortuosity. And so I've got a picture down here we could look at. This is kind of nice. The left ICA on this person has got a nice little kink in it. There's color changes due to direction. So, we start off, right on that, yeah. We start off going in this direction, then we turn up there. As far as the transducer is concerned, there was a change in direction, even though obviously the vessel is just going along as. Well, we have combination here of aliasing and a change in direction there. So that actually presents a very confusing view, but there is some aliasing there. Some aliasing around here. So you notice that where it kinks hard, there's aliasing. And if you were to put your spectral there, it might not be the best place. Or at least it might, not a bad idea to look at it. It just might not record it if you are convinced that there is no plaque and everything you're seeing is just simply curvatures. Now dissections, I know we've mentioned this. And so what I've drawn here, I'll zoom up a little bit more, I decided to throw two dissections in here. Let me cover the first one, this top one. So a dissection is generally going to be a tear. Now, they also call them intimal flaps. Just an intimal flap is just a small dissection where it's just starting to like it's just starting to wave. Whereas a true dissection is where it's really starting to peel away. And so this is peeling away. Now remember, we have to think about this in 3 dimensions. This isn't simply a 2-dimensional object. So there might be an opening over on this side. And this could be wide open, but remember this wall, and obviously back here, but completely along here, that's still attached, like the arms are reaching out, still holding on. So this is called a blind end. Now on a blind end, you could have blood flow going past and everything. Anyway, blood going off in this direction. And depending on where you are in the heart cycle, you could have what appears to be blood flow going in the opposite direction. Now that's just simply blood getting knocked around. Here, the blood's going forward, finding a dead end, and then just bouncing backwards. So you might get a little bit of red, blue bouncing back and forth with every heartbeat, whereas the blood here is doing what it's supposed to do and traveling in one direction. Now, the one I drew below, I didn't finish. I want to keep that open. Oh, shoot, I need to get to another layer here for a second. Okay. Now, think of it as a, I like to think of this as like opening up a garbage bag. You know, people will take it and we'll shake it. We'll shake down really hard, trying to get air into that bag. And it's kind of the same thing. It's like this bag is opening. And theoretically, if you shook hard enough, you had enough air blow through, you can get a tear at that end. In which case, when we see this, let's give myself a nice big. In this case, blood is going to be traveling, well, it's going to be traveling along the way we expect it to be traveling through this vessel, but it's also going to be traveling in that direction as well. This is a little harder to see because, well, one, it's the intima. It's oftentimes very thin. And we're accustomed to seeing, let's see, when we look at this guy here, well, we kind of get used to seeing what basically amounts to reverb artifact inside of the vessel. And what a reverb artifact is, this is a, it's a false image of the wall. So we're going to talk about this more in the future, but basically sound is bouncing back and forth. When it bounces back and forth, the timing is off. And so by the time the echo gets back to the transducer and the machine is saying, well, it took X amount of microseconds. That must mean there's something there, and it's actually not there. It's false. So we do get reverb artifacts all the time, and that could really kind of mess with us. So you do have to pay attention. Every time I see something like that, I say, okay, probably a reverb artifact, but then I think, is it really? Take a second look, satisfy myself. So far, it's always been a reverb artifact. But I saw a really cool, and I tried finding this video, and I can't find it again. A guy proved this really well, and I'll show you how he proved it. It's pretty cool, actually. He put an M mode line on it. So I'm not going to draw out the whole thing, but as you can imagine, with the M mode, was able to see this guy going up and down with every heartbeat. It's flapping around, and it was very clearly shown in the M mode, just like I showed M mode, was it yesterday? Very clearly shown. So that was a pretty cool thing to use M mode to show that. These guys can start at the arch. In fact, that's probably the most common location, is the arch of the aorta as it's coming out of the heart. And I've actually seen a lot of those over in my buddies in CT. I'd go over and we'd be looking at someone with a dissection in the arch. Those can be pretty dangerous. And that flap, if it flaps around and plugs up a vessel, it could very easily do that. And so dissections are a big deal. They could close branches off instantly, and you suddenly are in crisis, or they can just continue to grow and grow and grow. So they can start at the arch. They can start in the ICA as well. When they start up there, it's usually trauma, or it's oftentimes trauma. And so it's trauma. I saw an article a couple years ago where a girl got hit by a wave, knocked her head back, thought nothing of it. Later on, she had terrible headaches. They did some scans and they found that wave, that stretching of her neck was so severe that it actually tore the intima. That's one possibility. Blunt trauma, all that stuff can cause it. Blunt trauma could also damage the vasa vasorum. That's the blood vessels inside of the walls of your blood vessels, feeding the walls. Well, if they tear and bleed, they could bleed and push that intima layer out, and then eventually it tears, and that's what causes it. Hypertension is another one that people oftentimes have. The other one is Marfan's and Ehlers-Danlos. These two guys are connective tissue disorders. Tall, lanky, hyperflexible people, hyperflexible tissues. So that, these are the people who could like pull their lip over their over their nose and forehead. For whatever reason they want to do that. But the connective tissue disorders do cause some problems, of course. So here's a picture here of that is a open dissection. So there's blood both traveling in the correct direction. You can see there's a different velocity of the two flows. But that's open at either end. So if you didn't throw color on, you might not see that. In fact, that's a really, I don't actually even see the layer itself. I just see the two color layers, of course. All right. So those are those guys. And of course, these can go, if they're in the arch, they could also go down into the aorta. We'll learn about that next semester. Oh, my computer's about to crash. Hold on. Okay. Oh, good. Did not crash. We've mentioned this one already, fibromuscular dysplasia, also called, we should go by its FMD. So whenever you see FMD, that's what they're talking about. More women get fibromuscular dysplasia than men. It's a fibromuscular dysplasia. So the intima media layer in areas is growing too much. And I think I told you guys a story of this lady I had, and she clearly had fibromuscular dysplasia, but I was dealing with these this is teleradiologists, and they were really bad. And the guy I told him, this is fibromuscular dysplasia. And he wrote back on the report that it was plaque, which it was not plaque. There was no plaque at all, in fact. So what I'm drawing in really here is just kind of an overgrowth of the muscle. And we see it like this. Remember, this is a three-dimensional object here. If we were to see this in transverse, the muscle all the way around, circumferential, is kind of tightening up there, and circumferentially tightening up there and around there as well. And so we get a lot of aliasing here. So it's going to be a bit of a, oh dear. First of all, you're too big. Second of all, you're wrong color. So we'll throw a little colors in here. Kind of indicate that there's aliasing. And if there's aliasing, well, it's also because of, well, okay, good enough. There are some velocity increases. So when I discovered this on this lady, yeah, she had some velocity increases, not horribly, not terribly high, but maybe up to 200 centimeters per second, which is, you know, high enough to cause some concern. At presentation, 20 to 50 years old, the main place that we actually get fibromuscular dysplasia is the renal arteries, and that could actually cause uncontrolled hypertension, which we'll learn about next semester. But that when you mess with the blood flow to the arteries, you mess with your blood pressure to the arteries. To the kidneys, you mess with your blood pressure, because your kidneys are very involved in that, in keeping blood pressure correctly. ICA, this could be a young person who had a stroke or had evidence of a TIA, a transient ischemic attack. Even though plaque is not developing, just maybe a little bit of, let's make thrombus brown. Maybe a little bit of thrombus got caught in here. You know, just a little bit. And the flow in one of these sections got so slow that it actually stopped flowing, and then this guy, whoop, embolizes and takes off. So that's a possibility. These are also really important to see, because people who have fibromuscular dysplasia have a very high prevalence, 30%, of getting Berry aneurysms. I'm going to show you what a Berry aneurysm is. This is an image of the circle of Willis. Let's see. This is, these are anterior. This is the vertebral vessels come up here, back here, and the blood goes around this way, comes up, goes out. These are middle cerebral arteries. But in any case, what you can see right here is a little circular aneurysm. So when you talk about brain aneurysms, this is what you're talking about. A brain aneurysm is generally going to be called a Berry aneurysms. And they are shaped like a little berry on a branch. So that's why I drew that as our Berry aneurysm right there. Now there was some discussion about one of the presidential candidates having aneurysm surgery, 2 of them. Well, that's actually not a concern to me. That in and of itself is not a concern to me, because that just simply means that through some kind of imaging, doctors were able to find these berry aneurysms in their head. And they went through and they basically tied them off before they ruptured. See, a little tiny aneurysm like that is not a problem until it ruptures. Then it's a problem. But so you guys, all of us, we could have an aneurysm sitting inside of our head right now. We would not know it at all. No effect until it ruptures. And the thing, here's a funny thing about, because I had to look this up. I was like, that's just weird to me. Because people get brain surgery and they do fine afterwards. They even have you know, maybe even a small gunshot wound to the head, and as long as they get the surgery quick enough, they recover pretty well. And so, why are these little brain aneurysms causing so much trouble? Because it's, you know, they say, oh, blood on the brain, blood. You don't want to have blood on the brain. Fresh blood is not the problem. Blood, when it's starting to get reabsorbed by the body, broken down by the body, that's actually the problem. So it's the fresh blood doesn't kill the brain. It's the coagulated blood. It's blood that's starting to break down for some reason. And actually, that part I still don't know. I think the chemicals released at that point damage brain tissue. So if you get to the hospital fast enough to have your brain cleaned. When I was a new tech, I used to go in on brain surgeries all the time, and it was interesting for about 10 minutes, and then it was horrible. I'll tell you a little quick story, because the surgeon he had to use ultrasound to find the tumor during surgery, because on imaging, CTs, you could clearly see the tumor. But when he's looking down into a brain and there's blood and the tumor happens to be the same color as the brain, he wasn't really able to see the tumor all that well. He could barely make it out. So what he would do is he'd irrigate the brain, kind of fill it with water, fill the hole he was making with water, put the transducer down, clearly see the tumor, remove the transducer and start digging away at the tumor. And he was using this tiny, tiny little scoop for hours. At least it seemed like many hours of just scooping away at this tumor. So I offered a melon baller. Didn't go over well, but I just wanted out. So I'm one of those techs who does not like going to surgery. I'm bored by it. Other techs like. And actually, most of us don't go to surgery anymore. They usually have their own little ultrasound units. It's nothing complicated. They just stick the transducer on, look at something, and then continue to cut away. But anyway, I digress. So we have a okay. So a little evidence of fibromuscular dysplasia. It's kind of like all these different colors, and you really can't see any plaque at all. It seems like it's filling wall to wall. Perhaps you actually see the string of pearls sign or string of beads sign, which is kind of a boom, 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 boom appearance to the vessel. But certainly very disturbed, very turbid flow. What, turbid? What am I? Anyway. But you could see that this top, like I call like hair almost on top of the vessel, and then there's absolutely no window at all down here. So that is very disturbed flow. Ah, yes. Now here's something we have not spoken about. and that is the carotid body. The carotid body is a normal thing. The carotid body tumor is not so normal. The carotid body, if you look at this first vessel, I'm just going to draw in a very small carotid body because that's about how big it is. Normally not visible by ultrasound, and it is right there at the junction of the ICA and ECA. It's a chemoreceptor. It kind of tastes, and this is really weird, guys, but the same cells that are like taste buds on your tongue, there's very similar cells on chemoreceptors like this. So it literally is tasting the blood. But it could taste for pH, carbon dioxide, and oxygen levels. It also does a really quick job.
Were you pointing at the black dot or the blue area?
Yeah, the black dot there. The blue was just artistic license. I was putting in a little change in direction for the bulb. Blood pressure. You stand up real fast and you have a moment of, you have a moment where you feel like you're going to pass out. This blood pressure carotid body, this chemoreceptor also checks for blood pressure. And as soon as your blood pressure drops like that, it says to the heart, oh, beat harder, 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 faster, faster. And so quickly your body recovers, hopefully. These guys turn into tumors, benign tumors. They're rarely cancer, but they can certainly turn into a tumor. So let's see, I'll stick with black and I'll use this guy. It could be a little hard to see. Now, a lot of the pictures you see on the internet and also in your book, the tumor itself is pretty easy to see. That's not always the case, though. The tumor can blend in pretty well. So you kind of have to be paying attention. And here's a recurring theme that we're going to see. I'm trying to think of a smart aleck thing to say to John, but this is a recurring theme. All throughout the body. When a blood vessel, I wouldn't say all throughout the body, but in the neck, in the abdomen especially, when a vessel suddenly does something unexpected, there might be a reason. It might just be tortuosity of the vessel. It could just be a weird way the vessel grew. Or, you never know, it might be a carotid body tumor in this case. Lymph nodes do this as well. Lymph nodes can be quite large, and depending on their surrounding, they can be kind of hard to see sometimes. And if you see a vessel just kind of change direction for no other reason, stop and think about, why did that happen? And then take a second look, and suddenly you might be looking at a tumor that, oh my God, I can't believe I almost missed that. Well, like I said, these guys are benign. They're non-cancerous. If they grow large enough, they can cause some hoarseness, difficulty swallowing food, difficulty speaking or breathing. Let's see, this appears to be, that's not really well seen. Let me circle. This is transverse. God, I could barely see this. ECA, ICA and ECA, and then a whole lot of stuff in between. Now we do have a lot of lymph nodes in the neck too. So this could be a lymph node. But then when you look at it sagittal and you see the vessels really going around the tumor just like that, you're starting to lean towards carotid body tumor. But All right, let's see. Aneurysms and pseudoaneurysms, I know we've spoken about this, but I think we do want to be a little more. So if this is a CCA, and I kind of regret how I drew this. Let's see if I can. Well, that's okay. Because what I was trying to show here in this true aneurysm, this is a true aneurysm. Ooh, wow, I spelled it right this time. Generally speaking, it is a 50% increase or 1.5 times increase over the normal size. So if this is the preceding segment and that's normal size, and if this is greater than 50% in size, greater than it's considered an aneurysm. The reason I've done this could be, we could be looking at two different things here. We could be looking at atherosclerosis. Atherosclerosis plaque weakens the wall, and so it can actually be the root cause of an aneurysm. Or the other thing we could look at is just remember in aneurysms, we always have to worry about thrombus building up. So we can call this athero question mark, thrombo question mark. Either way, there could be something in it. Athero causes them. Thrombos are caused by them. Thrombosis is caused by them. So this is not the bulb, by the way. This is like, you know, mid CCA. And the, you know, create the bulb would be over here. These are rare in the CCA. Rare to see. Then we have pseudoaneurysms. Now, I wish there was, let's see, pseudo, kind of meaning fake, aneurysm. There's two kinds of pseudoaneurysms. I'll do this one first because it's right there in our field of view here. And what happens is there might be a tear in the intima layer, perhaps the media layer as well, but in any case, with a pseudoaneurysm like this, there is a loss of the three layers. So in this case, we have a one layer pseudoaneurysm, and you get a yin-yang appearance because blood is swirling around in there. By the way, it's always a good idea. The doctors like to let's see. Measure the opening if you can. Measure the length of the neck, maybe. If it's especially if it has a longer neck, measure that. They like to see measurements. They also would like to see a spectral right here, because what they're going to want to prove is that the blood flow is going forward, backward, forward, backwards. This is called to and fro flow, and that makes sense. It's going in, kind of fills the pseudoaneurysm, and then as the heart is relaxing, it comes flying back out, and then it goes in and out, in and out. So the blood flow is truly just kind of going, whoop, going in, swirling around, coming back out. And so it's constantly doing that. So that's a pseudoaneurysm. A pseudoaneurysm has at least one wall layer left. The adventitia has to be there. It could be adventitia media, but perhaps just adventitia, because that's kind of like the last bulwark against completely rupturing. And of course, you don't want to see these rupture. The other kind of pseudoaneurysm, I think I told you guys a story where when I was a student, the doctor punched a hole, a good size hole, not just a tiny little needle, but an actual, like a really thick needle, a very large bore needle, punched it right through the CCA. And it was really fun because what I saw instantly was, I need to have the right color. Why do you keep doing that to me, computer? Blood just doing this. And of course, it doesn't just come squirting out and going all over the place. We're packed pretty tight. So what I've drawn here is trying to show all the layers of fascia and muscle and everything. That holds the blood from just going everywhere. So it creates, this is another kind of pseudoaneurysm where all three layers of the vessel have been torn open or poked open in this case. And the blood just swirling around. And so what the doctor had me do, which was great, it was, I was still a student and I was helping someone stay alive. I just held down on it, and with compression, you can hold these closed, and if you hold them closed for 20 minutes or so, if they have enough platelets in their blood, they will close up automatically. Which is one reason, by the way, we always check blood clotting before any procedure, even something that just as simple as very small cuts, very small needles, well, not super small needles, but relatively small needles. We still want to know what the blood clotting is for patients because it can get ugly. So let's see, I have here, actually this is an interesting, this picture is interesting here. This is the proximal carotid. It says proximal, and the diameter is quite large compared to, let's say, right there. Now this person has another thing going on. It's actually interesting. I looked this up. Finding a carotid aneurysm is very difficult because these are really rare. They don't happen very often. You'll probably never see one. But look at the thickness of this person's walls. This is like crazy thick walls. And so this person's aneurysm, which is definitely, this is definitely an aneurysm, that's very large right there, wasn't caused by atherosclerosis, probably not caused by Marfan syndrome or anything like that. They have an arteritis going on. Actually, that's the last thing we talk about today. So that was a really hard picture to find. It wasn't very good. Actually, and I don't even think this one is actually even the CCA. Because the most common place for this is a pseudoaneurysm, by the way. That other one was this is a true, and this one's a pseudo. The most common place we find these is in the femoral artery. Why? Because that's where doctors stick their needles. So usually that's caused by, a doctor. But on this one, we could measure that. Like, what color is not being used here? I'll try green. Once again, I can measure there's no way to measure the length of the neck here, but I would measure the width. I would put a spectral right here just to prove what I'm seeing. It's pretty obvious what we're seeing here, but putting a spectral there and showing the to and fro blood flow is nice for the doctors. They get to, you know, you're just further proving what is sometimes fairly obvious. So we could fix these as well in the thigh. Like I said, I'm pretty sure that's not actually even the carotid artery. One picture I don't have, this is the next thing in your book. Man, I just couldn't find anything on, as far as an imaging of post-radiation therapy. So the reason why we use radiation and chemotherapy, for that matter, both of them, they attack certain cells preferentially. They attack cells that grow quickly, which is why you lose your hair with either radiation poisoning or chemotherapy, because your hair cells, your hair follicles are very, very active. Your hair is, well, most people's hair is always growing.
Except yours.
Thanks for helping there.
Well, what's up with yours, John? It's going out too, just like mine.
So it attacks fast-growing cells. It also attacks. It tends to attack endothelial cells. Endothelial cells, you'll see a lot of those lining the vasa vasorum, and so you could, on the larger vessels, you can kind of destroy the vasa vasorum. Then the body comes in and says, well, now we need new, new blood vessels. So angiogenesis, new blood vessels are coming in, and new tissues coming in. And what ends out happening is you get walls that are thickened and ugly. So on a person with a history of radiation therapy, you can take a look at their history and say, okay, they have a history of radiation to the neck. I'm getting a really ugly picture. Maybe that's what's going on. Like I said, I could not find anything. You can, thickening of the vessel walls and stenosis, but the image can be
You couldn't
similar.
find anything in MR on that?
I probably could, but I really wanted an ultrasound image. And actually next semester, I do a lot of MR and CT imaging because it really helps when we're able to read those too. So I grabbed this one. This is not radiation therapy, but it is very, very thickened walls. And this isn't intimal hyperplasia either. Actually, that other picture we just had, let me just quickly run over here. This could be something where if the patient had a history of radiation therapy, you could say, well, this could be evidence of tissue damage due to that therapy. Okay. All right, guys, just one last thing to talk about today. It's two different arteritises, but they're, and boy, they hit kind of different people, a little bit different people differently. Takayasu's is a young women, 20 to 30 ages, 20 to 30 at presentation. So both of these have a female predilection there. Don't worry, girls. Ladies. It sounds like everything females get, but in the end, we die younger. So, so a lot of it only seems that way. We get ours too. A little more of an Asian, 20 to 30s. Giant cell is, this is actually greater than 40 at presentation. These tend to be white women. It can be men as well, but it's just more often in women. So what it is, they're both an arteritis, so like an itis of the arteries, an inflammation of the arterial walls. And they're both autoimmune. God, I couldn't. These are both autoimmune disorders. So I think women in general get more autoimmune disorders than men. So an arteritis of the vessel walls can really end out being what you end out with is thickened walls. So it happens around the aortic arch. It could follow the aorta down into the abdominal aorta. In some cases, it could follow all the way like to the renal arteries and everything. A little bit along here. It tends to stay more central, especially at Takyasus. It can go up into the common carotid artery. And in the case of giant cell, and this would differentiate it, is that it tends to follow also the ECA and branches. So it goes for some reason, it will follow up the external carotid artery and the branches. And so one of the easiest branches that we have to look at is the temporal. That's right on top of your temporal bone. You can find the artery there. And if we carefully follow that up, the artery should look clean, fairly thinned wall, because it's a small artery at that point. And if you push hard enough, it'll completely close. Normally arteries don't close, but this between the transducer and your skull, it's going to close. And if it's left open at all, or if it seems to be not fully closed, that's an indication that we have giant cell arteritis. That's kind of an ultrasound way of finding giant cell versus Takyasus. So we'll go back to these pictures again.
So just to be clear, because you may sound very simple, if the wall of the arterial area in Takyasus is thick, we can just assume that's Takyasus. It can't be nothing else.
It's most likely, yeah. And there's a difference in thickness because, boy, I mean, we could have an increased intima layer, which is only the intima. And as a vascular technologist, you'll recognize intima thickening pretty quickly because we see it all the time. But this is multi-layer here. Here's the intima, and then there's looks like a media layer here, and then another layer out here. And so in any case, the total thickness of the wall from here to here is very thick. If it were only the intima, it should be seen differently. But and by the way, women, when we say presentation, it could be weakness in the arms. Or they're doing something physical with their arms, and they get cramped really easily, and they can't figure out what's going on, and they'll do a blood pressure, and the blood pressure is kind of low. And what's going on? And because when you have a long stenosis like this, Bernoulli's goes out the door, and Poiseuille's becomes really volume flow. So the volume flow to the arms might go down. So that's one way of discovering it. But like you look at this, I don't even know what they're measuring here. because it looks like that's like the intima layer, and then maybe intima and media, and then further layers. So on this person, this is the outside of the vessel, and this is the lumen right there. So that's obviously going to cause some issues. Yeah, gosh, it's only 10:30. 1 hour class today. Not even, well, 10:38. We probably started 5 minutes late. 1 hour. Well, it is what it is. We have no worries about getting vascular done this semester, so that's okay. I'm behind schedule on vascular. I'll tell you what I'm doing for my other class. No, do I tell you guys that? Yeah. Well, okay. How about this? I'll guarantee you a test in the near future. Vascular classes, guys. We're not a vascular school, although we teach a lot of it. And it's important. Don't get me wrong. I'm not minimizing the importance of vascular, because you're all going to need to be vascular certified to get jobs in the future anyway. But I think our next, I think we're kind of behind on vascular testing. So the next one is going to be soon enough. Let me develop it. I've got test questions already. I just need to put them all together. And it'll be at home and open book. So what I'll do is it'll be timed, but you'll have twice as much time as I normally give you. Like in vascular, I'll give you twice as much time. The carotid artery, I just want you to learn it. But there's no national test that you're gonna be taking on the carotid artery anytime soon. So I'd rather you spend your time worrying about physics, hemodynamics, yes, physics, carotid, and all these things. I want you to know them, but I want you to spend a little bit less time on them and really worry about physics. So I'll create a test. I've got to figure out exactly what it'll encompass, and it'll be like 30 questions, but you'll have 2 hours to do it. So you'll have time to look things up. And I have advice let me give you advice really quick on that, and then I'll let you guys go. Anytime you have an open book and it's timed, do every single question you can without the book first. This is very important, because I gave a big test to a class once. It was a really important test. And I said, all right, guys, you know what? Open book. And as soon as I said, okay, start, they opened up their books and started looking up the first question on the test. The first question was easy, and they wasted their time looking it up. Most of them ended out not finishing the test, okay? So it's really important that when you do an open book test, but you are timed, to do everything you can first. Take notes, mark down what you want to go and look up, then go back and look things up. In fact, you have to make sure that you answer every question on a timed test, because it's a tragedy when people actually do worse because I give them an open book test, and I've seen that happen. So in case I forgot to remind you, I'm sure I won't, but in case I do forget to remind you, do the test first, then open your book. Okay. Oh, and I'm still recording.